So it's back to this issue of suicide and co-occurrence with self-injury. In a study that Jennifer Mellencamp and her colleague did and published in 2007, 50% of their community-based sample had a history of a suicide attempt. So these questions are important. 70% of inpatients had co-occurrence in a study by Matthew Knock and colleagues. And 73.8% of our sample from the previous study that I was talking about, who had repetitive non-suicidal self-injury, had at least one suicide attempt in the past 6 months. So in the study two studies that I'm aware of that have been done looking at this issue, when they look at the profile of these youth, self-injurers who are more likely to attempt suicide have a number of things in particular. They seem to be more repulsed by life. They seem to have greater amounts of apathy. They tend to be more self-critical, have fewer connections with their family members, and less fear about the act of suicide itself. So those are a couple things to think of when you're assessing these youth, to probe in those kind of areas to help you determine suicide, potential presence of suicide as well as suicide risk. When we look at co-occurrence of mental health problems, there are a number of psychiatric diagnoses that can co-occur. In fact, there's a large number of them in general, including mood disorders, depression, bipolar disorder, bipolar 1 disorder, bipolar 2 disorder, anxiety disorders, eating disorders, ADHD, and substance abuse. The issue of borderline personality disorder, I think, is quite debatable. I do not use this diagnosis in youth under the age of 18, and I certainly don't use this diagnosis when I feel there is a untreated or undertreated axis 1 disorder. It's not to say that there are not issues around attachment, temperament, etc., but I tend to be leery of this because my experience is once they get that label, it tends to really stick, and it's not always helpful. The issue of abuse, sexual abuse, physical abuse, has always been put to question in relationship to the self-harm behavior because it has an self-abusive aspect to it. David Klonsky, who is now here, professor of psychology at University of British Columbia, did a study where he reviewed the literature and found only a modest association between childhood abuse and non-suicidal self-injury. What he did was he looked at 43 studies and came to the conclusion that child sexual abuse was considered more a proxy risk factor for self-injury, in that child abuse may play a role for some regarding their non-suicidal self-injury, but there are many who self-injure who have not been abused, and many who have self-injury, many who have abused who don't self-injury, and many who have self-injury have not been abused. David Klonsky and Jennifer Mellencamp published a study in 2007 and looked at psychological characteristics of those with non-suicidal self-injury, and they came up with 3 key areas in terms of emotional states. And one being negative emotionality, that these people tend to have more frequent and intense negative emotions, that they tend to have definite deficits in emotion skills, such as difficulties with their experience, not always aware and able to express their emotional states, and they tend to be self-critical and have self-directed anger. This is a more recent publication that's out by Matthew Knock, which is an excellent review of both distal risk factors that are present in the literature and the research thus far, as well as more proximal issues such as stress and stress response. I apologize because the font is a bit small in this slide, but I'll just go over it quickly. So in terms of distal risk factors, you can look at things for genetic predisposition for this high emotional cognitive reactivity that we were talking about, issues related to abuse or maltreatment, and familial hostility or criticism. Then you have interpersonal vulnerability factors, such as high aversive emotions or high aversive cognitions and poor distress tolerance, mixed with interpersonal vulnerability factors such as poor communication skills or poor social problem solving. Tie that in with type of stress response that a stressful event triggers, or either an over and under arousal, or it presents an unmanageable social demands. And then more specific factors for those with NSSI related to different hypotheses that are listed there, whether it's self-learning behavior, whether it's a self-punishment behavior, whether it's a social signaling communication behavior, whether it's just a very pragmatic behavior, whether there's some kind of pain analgesia or an opiate type of influence here that causes the behavior to reoccur. We have also looked at addictive aspects of this behavior and something called the implicit identification hypothesis. And then there's some back kind of reinforcement arrows on that. So there's a lot in that slide, and as we mentioned, these are on the website and you can take a look, and you can also look up that article, which is a nice review. So things to consider when we want to assess a youth who presents with this kind of behavior. Many youth feel very embarrassed, feel very ashamed, feel very reluctant to discuss this behavior. And it's a very delicate approach and balance that one has to take to build up the therapeutic alliance, to use a non-judgmental approach, to create the atmosphere for the exchange to occur for these youth to share what's going on. Many youth come in, and they don't come in because they see it as a problem. They come in because the school counselor has indicated to a parent that they've noticed this behavior, or the school counselor has encouraged them to at least check it out with somebody. Many feel that it's been going on for so long they don't see the point in changing. Many feel that it's providing a function for them that is so successful that they really don't want to consider any other options. So it's really checking in where they are at and acknowledging and validating that aspect of things. We always recommend a stepwise approach to the assessment, starting with a risk approach. We use self-report questionnaires, which I'm going to actually review with you today, some of them, and we use these aspects of our assessment to kind of determine and triage what kind of treatment approach might best be applied and what type of referrals we might need to make out of this. So here's a bit of a stepwise approach, and this is reviewed. Nancy Heath was the first author on this chapter in our book, the issue of screening and triage, moving to a basic assessment, always addressing the issue of safety from the suicide risk perspective, which we will not go into today. That's a whole separate piece of training, and medical issues like how severe might be the wounds and do they need medical attention. And at any level, they might move off to some kind of intervention or move on to a more complex assessment, which may include seeing a psychiatrist, for example, or a referral to a family therapist, for example.